So we'll have another, I'm sure, stellar presentation by Dr. Oliver regarding the data and clinical considerations for additional doses in immunocompromised individuals. Please, Dr. Oliver, take it away.
Thank you and good afternoon. Next slide. So today we'll review the COVID vaccine response among immunocompromised people, the response to additional dose of COVID-19 vaccine among immunocompromised people, and then finally, frequently asked questions around vaccination in this population. Next slide. So this slide outlines the process for additional doses in any population, but what we're discussing today among immunocompromised people. First, we will review the data, where we assess the safety, immunogenicity, and implementation of any updated guidance or recommendation. Then there would be regulatory allowance by FDA. There's a variety of different mechanisms by which this could happen. For example, one way is an EUA amendment that would allow for recommendations under EUA. Another possibility is a BLA, which would allow for ACIP to make off-label recommendations, as is done for a variety of other vaccines. Once there is regulatory allowance, CDC or ACIP could have a clinical update with clinical considerations or recommendations for use. Next slide. For today's presentation, we're in this first phase reviewing the data. Next slide. We'll start with that data review with COVID-19 vaccine response in immunocompromised people. Next slide. It's been estimated that immunocompromised people comprise around 2.7% of US adults, including people with cancer, organ or stem cell transplants, severe primary immunodeficiencies, persons living with HIV, and treatment with immunosuppressive medication. Next slide. Data from the pandemic also show that immunocompromised persons are more likely to get severely ill from COVID. They're also at higher risk from prolonged SARS-CoV-2 infection and shedding, viral evolution during infection and treatment, and to potentially have low antibody titers to SARS-CoV-2 variants. In addition, they may be more likely to transmit SARS-CoV-2 to household contacts. And finally, recent studies have demonstrated a higher proportion of vaccine breakthrough cases that occur among immunocompromised people. In one US study, 44% of hospitalized breakthrough cases were immunocompromised, and it was 40% in an Israeli study. Next slide. So this slide summarizes the vaccine effectiveness studies among immunocompromised persons for mRNA vaccines. One study evaluated VE 7 to 27 days after a second dose of the Pfizer vaccine, with 71% VE against SARS-CoV-2 infection compared to 90% overall. VE was slightly higher at 75% protection against symptomatic COVID. Another study, at least 7 days after a second mRNA vaccine dose, found 80% VE against SARS-CoV-2 infection among people with inflammatory bowel disease on immunosuppressive medications. This study also found that VE was quite low at 25% after the first dose. And finally, another study evaluating VE at least 14 days after the second mRNA vaccine dose found 59% VE against COVID hospitalization from 14 days after the second dose among immunocompromised persons, compared to 91% among those without a documented immunocompromising condition. And it was this specific hospitalized cohort where 44% of breakthrough cases had a solid or hematologic malignancy or a history of a solid organ transplant. Next slide. This slide was shown at a prior ACIP meeting. We've updated with additional studies since the last meeting, but you can see that this slide shows the percent of subjects with antibody response after 2 mRNA vaccine doses by immunocompromising condition and study. Hemodialysis patients in green have the highest proportion with an antibody response, and those with a history of organ transplant have the lowest percent response in yellow. In general, studies that were able to compare response after dose 1 and dose 2 compared poor response to dose 1. Next slide. So now moving to the emerging data on a response to an additional dose of a COVID-19 vaccine in immunocompromised people. Next slide. This slide shows 4 studies that look at the antibody response in immunocompromised populations. The optimal data in this situation would be to have clinical VE documenting protection against infection or illness. However, in many circumstances, we only have data on antibody response. And while it may not tell the full story, we can learn something from this data. In the first set of columns on the left, you can see the proportion with an antibody response after a 2-dose mRNA vaccine series. Then the data on the right of the table shows response after a 3rd dose among those who were seronegative after the 2nd dose. While many of these studies have small numbers, you can see that among those who had no antibody response to an initial mRNA vaccine series, 33 to 50% did develop a detectable antibody response to an additional dose. Next slide. So this slide shows data in detail from one of the studies described on the previous slide. The box on the left shows the prevalence of anti-SARS-CoV-2 antibodies before each dose and 1 month after the 3rd dose in a study population. The box on the right shows the anti-SARS-CoV-2 antibody titers for those same time points. Overall, in this organ transplanted study population, the prevalence of anti-SARS-CoV-2 antibodies was 40% before the 3rd dose and 68% overall 4 weeks after the 3rd dose. Then, as was shown on the last slide, if you only look at patients who had been seronegative before the 3rd dose, 44% were seropositive at 4 weeks after the 3rd dose. Next slide. In addition, no serious adverse events were reported after the administration of the 3rd dose, and no acute rejection episodes occurred. Now, next slide. So here we show data on the reactogenicity of a 3rd mRNA vaccine dose in a cohort of patients on hemodialysis. No patients developed side effects that required hospitalization. And on the figure, you can see symptoms reported after the 3rd dose were consistent with what has been seen after the 2nd dose. Most symptoms were mild in yellow or moderate in orange. Next slide. We also note that internationally, several countries have commented around policies for additional doses for immunocompromised individuals. France has recommended that a 3rd dose 4 weeks after the 2nd dose be given for patients who are severely immunocompromised. The UK has a proposal for additional doses of COVID vaccine for immunocompromised people 16 years of age and older, but a formal recommendation and decision is pending. And Israel announced a policy recently for an additional dose for people living with organ or stem cell transplants, blood cancer, autoimmune disease, and treatment with specific immunosuppressive medications. Next slide. So in summary, immunocompromised people are at an increased risk of poor outcomes from COVID. Studies indicate a reduced antibody response in immunocompromised people following a primary vaccine series compared to healthy vaccine recipients. Emerging data suggests that an additional COVID-19 vaccine dose in immunocompromised people may enhance antibody response in some and increases the proportion who responded. In small studies, the reactogenicity of a 3rd dose of mRNA vaccine was similar to prior doses. Next slide. So finally, moving to frequently asked questions about vaccination of immunocompromised people. Next slide. So first, to address which immunocompromised groups should be considered for an additional dose once allowed by regulatory mechanisms. It's likely that the most benefit would be focusing on conditions and treatment associated with moderate to severe immunocompromise. This would include those on active or recent treatment for solid tumor and hematologic malignancies, receipt of a solid organ or recent stem cell transplant, severe primary immunodeficiency, advanced or untreated HIV, and treatment with immunosuppressive medications as listed here. There are chronic conditions associated with varying degrees of immune deficit, such as asplenia and chronic renal disease. Different medical conditions and treatments can result in a wide variety in varying degrees of immunosuppression. And a patient's clinical team may be able to assess the degree of altered immunocompetence and optimal timing of vaccination. Next slide. So next, should immunocompromised people undergo antibody testing following COVID-19 vaccination? The utility of serologic testing or cellular immune testing to assess immune response to COVID vaccination has not been established. The exact correlation between antibody level and protection from COVID remains unclear. In addition, commercial antibody and cellular immune testing may not be consistent across laboratories. For all of these reasons, serologic or antibody testing or cellular immune testing to assess response to vaccination outside of the context of research studies is not recommended in the US at this time. Next slide. Are there data to support a mixed dose series in immunocompromised people? For example, a Janssen vaccine followed by an mRNA COVID vaccine. Studies in Europe have assessed heterologous primary series, specifically an AstraZeneca and a Pfizer vaccine, in the general adult population, and found immunogenicity to be at least equivalent to a homologous series. There was a large UK trial, the COMCOV study, found that one dose of AstraZeneca plus one dose of Pfizer resulted in superior immunogenicity compared with 2 doses of an AstraZeneca vaccine, but lower antibodies than 2 doses of Pfizer. In addition, there was an increase in systemic reactogenicity observed with heterologous schedules. However, evidence is needed regarding the safety and immunogenicity using a mixed dose approach with mRNA vaccines and a Janssen vaccine, which is the advector vaccine authorized in the US, and in immunocompromised persons. Next slide. So following COVID vaccination, what infection prevention measures should immunocompromised people maintain? Immunocompromised people should be counseled about the potential for a reduced immune response to COVID vaccination and the need to continue to follow prevention measures, such as wearing a mask, social distancing, and avoiding crowds. Recall that in general, less than half of the immunocompromised persons had a detectable antibody response after an additional dose. So these measures should be maintained for immunocompromised persons, even if additional doses would be given. And finally, close contacts of immunocompromised people should be encouraged to be vaccinated against COVID. Next slide. Is there a role for monoclonal antibody use in immunocompromised people? Monoclonal antibodies are currently authorized by FDA for emergency use in persons with SARS-CoV-2 infection who are at high risk for progressing to severe COVID and hospitalization. Monoclonal antibodies are not yet authorized for SARS-CoV-2 infection. However, studies are underway. Next slide. So what are the implications for an EUA of the COVID vaccines with respect to considerations for additional doses in immunocompromised persons? FDA has authorized mRNA vaccines as a 2-dose series and Janssen COVID vaccines as a single dose. At this time, there hasn't been data submitted to FDA to support amendments to the EUA for this population. However, CDC and ACIP will closely monitor for any updates to the data and to regulatory mechanisms. Next slide. So as a reminder, this is the pathway for additional doses in immunocompromised people. We will continue to review the data as it becomes available. However, while we do that, next slide, we need to remember what we can do now. First, immunocompromised people should continue to follow infection prevention measures. Close contacts who are of age to be vaccinated should be vaccinated against COVID to protect their immunocompromised friends and family. And remember that early treatment with monoclonal antibodies may be beneficial in this population as well. Next slide. So what are the next steps? We will assess additional studies of safety and immunogenicity of additional doses in immunocompromised people. Assess additional studies and expert opinion regarding subpopulations of immunocompromised people who may benefit the most from an additional dose. Determine acceptable intervals as well as mix and match schedules. And all of the data can support a regulatory allowance, which could possibly include an FDA amendment of the EUA or a BLA for additional doses of COVID vaccines, and we'll closely monitor. Next slide. So we have a few questions for ACIP. Next slide. What additional data do ACIP need to inform these discussions? And what are your thoughts on the focus of moderate to severe immunocompromised populations once additional doses are authorized or approved? That's my presentation, so I'll turn it back over to you, Dr. Romero.
Thank you again for a wonderful presentation, Dr. Oliver. Seldom, if ever, topped. Let's go ahead and take questions or comments. Dr. Fry, please.
Thank you. Thanks for a great presentation. That was really good. I had a couple of questions that I'd like to put on the question list for further consideration, and that is, in those people who did not respond to vaccine after the first 2 doses and then received a 3rd dose, is there a rule for a 4th dose to complete a 2-dose series? The other question that we might want to have give consideration to, and I'm sure this was already done at some point, is how soon after monoclonal antibody administration would it be appropriate to then provide somebody with a vaccine? Thank you.
Thank you very much for those questions. Dr. Long.
Thank you. Gosh, that's wonderful. And, it does not get easier, does it? We like to lump people as immunocompromised, and, there are hardly 2, even with the same disease, who have the same degree and the same underpinnings of their immunocompromise. So it's really tough to try to put them in a single bucket. Do we have any information? I'm sure the pharmaceuticals must be trying to look at 3rd doses in healthy people with varying levels of antibody to begin with. I guess I'm particularly concerned about the possibility of giving 3rd doses with good intention to people who themselves have high antibody. That you're, especially mRNA, you're going to, put in the order, make a bunch of spike protein. If you have a bunch of spike antibody, is that what myopericarditis is, in fact? And or are there other things that would potentially increase the danger of this group? So both, I'm a little bit concerned about, just what you've shown us. There are probably 20 other examples of different relative amounts of immunocompromise. I'm a little nervous about hemodialysis patients and seeing their pretty robust antibody responses and thinking about giving them more vaccine if they don't need it. So I guess first question is, what do we know about giving doses to people who already have substantial antibody responses? And do we have enough studies coming along that we can, make more smaller buckets than this one lumped bucket? And I just don't know about the biologic response modifying agents. It just seems like that would make vaccines aren't going to work very likely. And so you then would have risks way out of proportion to benefits.
Thank you. Dr. Alt.
On slide 11, where the 4 studies are listed, have any of those authors published follow-up data about effectiveness in that 3rd dose group? That's what we're looking for it. I was trying to pay attention, but also glance back to see when they were published. So I'd be curious to know if there are research protocols going on specific to this third dose, and those four groups that published might be a good source of that.
Thank you. Dr. Paling.
Thank you for this really important conversation and great presentation. I've got two questions. One is the data that we've been looking at, the vaccine safety data link. Can we use that data and look at high-risk conditions and see who's having disease and get some population-based data that way? The second is there is great interest among the immunocompromised population to be vaccinated. And is there a way for us to do, for a study to be done so that people can enroll and we can get data out of it as we think about, and to give us guidance as to how to best move forward?
Thank you.
Dr. Paling, this is Amanda Cohn. I can answer your second question first, and then I'm not sure we totally understand the first question. So I think what you're asking about is, is there a way to offer a third dose to individuals who, through a study or through an investigational new drug format for this population? And I will just say that we are actively looking into ways that could be done to potentially provide access earlier than any potential change in regulatory decisions. So stay tuned. We are working through those issues. And then,
Okay.
Can you repeat the first question?
Sure. The first question is, so I'm looking at the focus on moderate to severe immunocompromised populations. What are the thoughts? If we're following 12 million people in the VSD database, is that a reasonable place to look to see who is immunocompromised, who's vaccinated, and what's their hospitalizations and disease, to give us some insight as to the groups to focus on?
So, Dr. Paling, that's also a great question. So you're asking if you could use a database like the vaccine safety database or other large data sets to try to look at potential vaccine breakthrough cases or other things. There are probably some other people who could respond better, but those types of protocols for types of studies like that are being developed and looked at. There's a lot of complicating factors in that. For example, a lot of people have gotten vaccinated outside those healthcare systems. And so there's a lot of work to make sure that the data are of enough high quality to conduct that type of analysis. I don't know, Tom, or if anyone else wants to respond to that from CDC.
Yeah, we'll move forward then. We'll follow up on that. Dr. Cotton.
Camille Cotton, thank you very much for the excellent presentation and very good presentation of the data that's available. This is a population that I've cared for over 20 years. They are at very high risk for disease and also potentially spreading disease at higher rates and for prolonged periods. They may shed virus at higher rates and longer, so really can potentiate the pandemic. The immunocompromised community is certainly aware of their risk, and I would just like to discuss the fact that many have taken matters into their own hands, and many are proceeding with additional doses of vaccine as they see fit, which is really challenging. It doesn't look like there's a significant safety signal as far as we know with additional doses of vaccine. I am concerned about them doing this kind of in an unsupervised fashion, but as it is right now, due to regulatory issues, we are not allowed to recommend additional doses. So patients are really just doing what they think is best. I have major concerns about equity because in my experience, I have noted that it is patients who tend to be more educated and more empowered to take care of their own health care who are getting these additional doses. So I worry that some are being left behind. Our hands are really tied with the current regulatory situation, and that is a challenge. So we definitely appreciate the support from the CDC, and I know that the FDA is understanding and probably working as hard as they can to fix the situation. Regarding looking at databases and vaccine efficacy, it's really hard in this population because the vast majority got the memo that they are at high risk for severe, life-threatening, even deadly disease. Just yesterday, I saw someone in clinic who had life-threatening disease several months after her second dose of vaccine. And she tells me every time I see her in clinic that she knows she almost died. They are really quite aware. So she was exposed in a healthcare setting where she had to go for healthcare because she had a kidney transplant. Vaccine efficacy will be really hard to evaluate in databases or to do comparisons because most of these patients did fairly extreme infection control measures, socially isolating, distancing, masking, et cetera. But in the meantime, we really, the transplant and immunocompromised host infectious disease community really appreciates the support from the CDC and forging ahead with all of this. So thanks for your support.
Thank you for those comments. Are there, Dr. Talbot, go ahead.
So this answers somewhat the question, but it really brings into light what I think is the most important part of protecting our immunocompromised population. So we all know someone in our life. We all have someone in our life who is frail, has an autoimmune disease, has cancer, who's had a transplant, or whose immune system simply does not work as it should. They may be at your work. They may worship with you. They may be family or neighbors or even friends. If you love them or if you care about them, you do not want them sick, or if you do not want to be the one to kill them, even if unintentionally, you need to be vaccinated. You need to vaccinate them to protect them. If you love your neighbor, you will get vaccinated. If you have questions about vaccines, I highly recommend you talk to your physician and tell them about the loved ones or the people that you care for in your life who have an immunocompromising condition. And I really stress, please talk to your primary care provider and not social media. Please protect the ones you love, and please protect your neighbors. Thank you.
Thank you very much. Dr. Freihofer, I see your hand up, and I'm not ignoring you. I see one more voting member. You will come right next if we don't have any more voting members that wish to make comments. Dr. Sanchez.
Thank you, Dr. Romero. This is a really, really difficult question, and what is appropriate given the really, we obviously need more data on the specific immunocompromising conditions and responses, and really, what is the a target level of antibody that we should seek. But it seems to me that it is that the issue is almost running away from us already, that this is happening. We want to vaccinate. This is something we, during this entire conference, we've been saying, vaccinate, vaccinate, vaccinate. These people want to be vaccinated. They're not vaccine hesitant. And it seems to me that we should promote that. And I know that we don't measure antibodies as a recommendation, but this is a population that gets antibodies measured for 1,000,001 other things. And if you do measure it, and after 2 doses, and the antibody to spike protein is low, I think this is a place for shared decision-making and at least allow it while we obtain more data and not have them go someplace to another state or someplace else where nobody knows that they've already gotten to. I think we really need to be cognizant of the issue and work with these individuals. Yes, absolutely, we have to do the cocooning effect that we do for my preemies, but we really need to help this population out more. Thank you.
Thank you, Dr. Sanchez. Are there any more comments from the voting members? All right, I'm turning it over to our liaisons. Dr. Freihofer, please.
Sandra Freihofer, American Medical Association, but I'm speaking as a practicing physician. I read in the media that there are about 13 million doses of COVID vaccine that are about to expire. And every day, vaccine doses are being wasted because there are not enough people that are showing up in line to take advantage of getting vaccinated. At the same time, we now have this Delta variant that's rampant and it's increasing rates of infection. And so now's a great opportunity for those who are not vaccinated to get vaccinated. And we want to make sure that there's vaccine available for them. But I really do share the concerns that have been expressed by our ACIP members about, our patients right now, they're immunocompromised, that are doing all they can do by getting vaccinated, by having their close contacts vaccinated. And it's not enough, that they're still not protected. I am very excited that Dr. Cohn expressed that CDC is trying to find a way to provide access to vaccine for these patients prior to a change in the regulatory decision. But as has been mentioned several times, this is running away with us. Time is of the essence. I appreciate how closely FDA is looking at the safety and how much research is being put into this decision. But I wish it would all happen faster.
Thank you for your comment, Dr. Freihofer. Dr. Golan, please.
Thank you, sir. Again, excellent presentation as always. And I do want to kind of dovetail on what Dr. Talbot was saying, because from real world experience, this is, and for the public listening, this is not just a bunch of doctors and scientists sitting around talking about data and very esoteric academic information. In my clinic yesterday, I saw 6 positive COVID patients come in. All of them were vaccinated, so they were not really doing poorly, but they got infected because one of their family members refused to get vaccinated. So their newborn baby now has COVID. The mother has COVID, and she spread it to the rest of the family because they were listening to social media and they weren't listening to their physicians. But fortunately, my patients were all vaccinated, so they weren't getting severely ill. But now we have people who are having children who are getting infected with COVID because they didn't create that circle of protection. So while I think it is important that we look at the issue of boosters, I worry that the boosters will not be any more effective in the immunocompromised population than the initial series. So while we do need to look at the issue of boosters, we really do need to stress, as we have been doing, the importance of creating the circle of protection for ourselves and our family, friends, and loved ones to get them protected by making sure everyone gets vaccinated. So it is real world. It is happening. It's not just something we discuss here at the committee and at the CDC, but it's actually being seen in the population. So all I can do is encourage that we do work quickly. We look at the science, the data, but we really focus on the need to vaccinate as quickly as possible, and that people will listen to that message and follow the science. Thank you.
Thank you for your comments. Dr. Dushin.
Thank you. Jeff Duchin, representing the Infectious Diseases Society of America. Excuse me if this was covered, but I'm wondering, because a BLA would allow for off-label recommendations and allow clinicians to use their judgment about administering another dose to immunocompromised patients, what the timing is for a BLA and what can be done to expedite the BLA process?
Dr. Fink, do you want to offer comment on that?
Sure, thank you. I just want to assure the committee and the liaison members and the public that FDA is working as rapidly as possible to conduct a thorough and comprehensive review of all regulatory submissions for COVID vaccines with the goal of ultimately approving safe and effective COVID vaccines for use in the U.S. We really appreciate the comments that have been made by committee members, by liaisons, and by the public about the need for better protection amongst immunocompromised populations. This is truly an important scientific issue and an important public health issue. And FDA is actively exploring all regulatory options for providing access to additional doses of authorized vaccines in situations where data suggests that the benefits would outweigh the risks. Ultimately, FDA is a data-driven agency, and so any regulatory action or any regulatory mechanism for access would rely upon submission of data, supportive data, to the FDA for consideration. Thank you.
Thank you. Ms. Bata.
Sorry, I had to find the unmute. Just a couple things. I too am feeling that the fact that this issue is running away from us. We have a few health systems here in the state who are already in the process of developing policies for vaccinating immunocompromised ahead of any type of authorization. And so that becomes a challenge. Again, as we heard about the equity, the people who are in the know will be able to rush to these sites and get vaccinated. And I don't know what the consequence of off-label use of an EUA is. Maybe Dr. Fink could tell us. And then the other question I had, and this is part of that, what additional data do ACIP need, would be, do we have data or is data underway regarding mixed series of COVID vaccines and among immunocompromised? And I'll stop there.
Thank you. Dr. Long.
Yeah, as I'm thinking about what you're all saying, these immunocompromised patients are not the general public. They're a group that are highly doctored who do, I agree, have lots of antibody tests, many of them not nearly as important as this one. So I'm wondering if Dr. Oliver would comment on her comment that there is great variability in COVID antibody measurement from commercial sources. And I totally agree with that. That's my experience, absolutely. But that's not the antibody we're looking for. We're really looking for antibody to spike protein. Do you have data that also is not reliably measured?
This is Dr. Oliver. I think many of these assays for COVID and for spike antibody are under EUA by FDA as well, and so I think there is concern that that there's just a variety of various cut points and thresholds across, and without a correlative protection, we don't know what testing positive on one test and negative on another test necessarily mean as it relates to vaccine response or clinical protection against disease. So I think that's the point. Is it could be difficult for an individual, a person, and even their provider to know with a variety of assays what a positive test or a negative test necessarily means with specific regard to vaccine response and vulnerability to COVID. So that was what that was referencing.
But may I ask you to clarify that again? I'm only interested in antibody to spike protein. Is that what you're talking about?
Yes, I mean many of our commercially available antibody tests are, most of them I think are to spike. So yes, there is still variety in thresholds and cutoff points as it relates to spike antibody tests.
Well, most patients who have had the vaccine have negative COVID antibody tests.
They would
and only have positive tests for spike antibody. So please educate me on what I'm missing here.
Well, so there's two different types of COVID antibody test. There's the spike antibody test and the nucleocapsid antibody test. And so most providers could order, a variety of those. So if you've had the vaccine, you would test positive for the spike antibody test. And then if you've had COVID infection, you would test positive for the nucleocapsid antibody test and potentially the spike antibody test as well. So I think there's both different types depending on there's a spike antibody and a nucleocapsid antibody. I'm happy to follow up with you offline to kind of walk through some of these issues, though.
Thank you. So I want to make sure that there's no other questions. Some of the previous commenters left their hands up. I just want to make sure, Dr. Freihofer, do you have another comment to add? And
I'm sorry, I'll take my hand down.
No, nothing to apologize for. I just want to make sure we're giving everybody a chance. Dr. Dushin, same with you. Dr. Fry, her hand just popped up. Dr. Fry.
Yeah, I just wanted to say that the spike protein will be positive in people who had vaccine. The ELISA antibody to spike protein will be positive in people who have received vaccine or were infected. The nucleoprotein ELISA assay would be only positive against those who were actually infected at some point. Thank you.
Thank you. Dr. Lee.
Thanks. I just wanted to respond to the two questions. I think that there is sufficient data to suggest that an additional dose would be helpful when allowed per whatever regulatory mechanisms is needed. I do want to just emphasize, though, that I think that safety monitoring will be important as a component of use. And in this case, it's going to be unclear, what the data looks like. I think today it looks reassuring, but we would want to just continue to monitor that if and when a future third dose is allowable. And then in terms of the moderate to severe, I think that the sentiment expressed by Dr. Oliver makes a lot of sense in terms of how we would think about it, but just recognizing that there's the immunocompromised population is quite a heterogeneous population, that those are examples, but not necessarily definitive categories. And so there has to be some clinical judgment allowed, since not everybody will fit neatly into one of those categories, yet they may be severely immunosuppressed. So just to clarify that in general, I think that makes sense. In general, I actually think a recommendation as opposed to shared decision-making makes more sense, because I think it's going to be a challenge, and the best way to provide access is to provide a straight recommendation instead of a shared decision-making approach in this case.
Thank you. Are there any other comments from either the voting members or the liaisons? Okay, I'm not seeing any. Ms. McDowell.
Dr. Merritt, thank you. I just wanted to state that I recognize right now we're talking about adults, but perhaps the next time we discuss it, I would be curious as to whether or not there are any studies being planned or any other issues being discussed related to that 12 to 18 age group. Thank you.
Thank you. Dr. Cotton?
I just wanted to second what Grace Lee just said about shared decision making, and this will be applicable for a significant number of people, so we really need to roll this out in an organized fashion. It can't be all shared decision making with individual patients and physicians. I think that that's not really tenable. It may slow things down. I mentioned the equity piece. I think it would need to be more of a broad scale recommendation for certain populations. So I just want to support what Grace Lee just said.
Thank you. Are there any other comments, questions? Okay. I'm not seeing any. So I want to thank you all for the time that you've given to this. I believe we are ready to adjourn. Is that correct, Dr. Cohn?
Yes, Dr. Romero. Before we adjourn, I just want to let everyone know that we do not currently have a COVID ACIP meeting scheduled. We do anticipate that there will be additional COVID meetings in the month of August. So be on the lookout on our CDC website for those additional times. We'll try to announce them as soon as possible.
Thank you very much. So with that, I'll adjourn and wish you all a good day and be safe. Thank you very much.